stromal cells that is rich in 5-alpha reductase. And as you know from physiology, this is going to convert testosterone to the most powerful androgen to man, right? To the dihydrotestosterone. And dihydrotestosterone is very important. Why? Because this is actually where things originate in the prostate itself in terms of hyperplasia and also cancer. Now, the epithelial component, as you can see here, is made up of these mature cells. Most of them are going to be large cells. So large cells in the prostate are actually what you would hope to see when you are looking at a histological section. What you see in this mature glands right here is that there will be actually ample cytoplasm, as you can see here, a lot of cytoplasm. As you go, it's similar to other actually epithelium if you look anywhere in the body. As you go towards the surface, you will see that there is less and less nuclei left, right? Now, very importantly, and then you see a little bit of stratification right here and there. Look where the mitosis is. The mitosis is limited, as you can see here. The tip of you see the tip of the arrow?
Yes.
This is where the mitosis is limited to the basal cell layer, to the most basal layer of the glandular epithelium. Now, beneath the glandular epithelium, there is a basal cell layer. Do you see that?
Yes.
All right, that sits actually in a cuboidal kind of, and in a transverse kind of actually orientation. That's a very important layer to see when you are examining a gland in the prostate. Why? Because carcinomatous glands or carcinomas will be missing this actually layer of basal cell. Sometimes it is hard to see because there will be what you call a thicker kind of section. So you're wondering if what you're looking at is actually a glandular epithelium or basal cell layer. For this, we do an immunohistochemical stain, or at least this is done. This was done and still is done actually in many places. Immunohistochemical stain known as known as cytokeratin 903. Cytokeratin 903, which is going to stain the basal cell layer for you. And will confirm that what you're saying is that there is a layer that surrounds actually this gland, meaning this gland is benign. Okay? One of the things that you may also do in order to figure out if you have a complete layer or interrupted layer is you go and actually cut the section that you have that is embedded in paraffin deeper. You take deeper sections of those. As you go deeper, you may start actually to see that there is a full layer, meaning you have cut what you would have thought is actually a missing layer of basal cell is simply an oblique cut that resulted in you seeing part of it and missing part of it. To see the full picture, you will send the same actually plot where the glands come from, and you actually have to go on deeper sections to make sure that the basal cell layer is complete. Now, this is how it used to be done before. The reason why this was so important was because we did not have anything that is going to pinpoint a carcinomatous gland for you. Now we have actually, thanks to molecular medicine, molecular pathology, we have stains that are going actually to stain the carcinoma carcinoma cell for you right off the bat. So instead of looking for an indirect evidence of benign gland, which is this basal cell layer, now you're going after the glandular epithelium directly. Okay? Something to keep in mind. You need, just for your information, you don't need to know it now, you need to know it for the medical school, but you need 3 glands in a needle biopsy to call it cancer. Okay? You need 3 small glands that fit the description of a carcinoma gland in the prostate, carcinomatous gland in the prostate, for you to call actually this a diagnosis of a microfocus of carcinoma in the prostate, as we will see in the next slide. So remember, basal cell layer is important. And you have the indirect evidence to do a stain for it. That's in the past, cytokeratin 903. But now we have a direct evidence, which is going to stain these cells right there. If it is carcinoma, it will stain it right off the bat immediately, without going to the direct, evidence. The indirect evidence, I'm sorry. All right, so starting with prostatitis, acute prostatitis, there are those actually pathogens that will do it. You will see that it's gonna be also split by age. Younger patients are gonna be having those STDs. Older patients will have actually more of an intestinal kind of origin for them. If this is not treated, or if this is not treated at all, neglected by the patient, or if this is treated inadequately or incorrectly, then this actually may become chronic bacterial prostatitis. Both of them make a small actually percentage of the overall incidence of prostatitis. The most common prostatitis is a much more sinister form of chronic prostatitis than both acute and chronic bacterial prostatitis, known as the chronic non-bacterial prostatitis, also known as chronic pelvic pain syndrome. This is actually when things really go haywire, okay? Meaning you have let it go for a while, and at the end of the day, you will see actually that the patient who is going to present with this, which is the majority of the patients, is not going to have any uropathogen that is present in the test that you are doing on him, whether by milking the prostate or actually looking at the urine. There is nothing that is growing actually, but there is presence of symptoms, very, what you call debilitating symptoms that are going to be there for a long time. Symptoms include dysuria, urgency and frequency of urination. This is actually similar to what you have in both the acute prostatitis and the chronic prostatitis on a chronic base, but you will not be having actually any kind of uropathogen that you can treat, that you can go after. Now, why is that the case? Let's see why is that the case. So when it comes to the chronic pelvic pain syndrome, for you to reach a diagnosis, it is a diagnosis of exclusion. So you have to exclude all the other entities where there is a factor that is causing, that could be causing the presentation of the patient, whether acute or chronic bacterial. And you have to fill in the US, that is what is known as an NIH symptom index, which is a survey by the patient. The patient has to fill it with a DRE, digital rectal exam, that you have to fill as well. Urinalysis and sequential collection of urine and prostatic fluid specimen after prostatic massage. That's actually, you're doing all of that to say that inflammation is present in the absence of infection. This is the reason why you're filling actually this NIH symptom index. And the symptoms actually, that appear in those patients are an interplay between psychological factors and dysfunction in the immune, neurological, and endocrine systems. So obviously it's a pretty complicated picture right there. And the theories behind it, we could only postulate why this is happening. That's a hypothalamic pituitary adrenal axis dysfunction, adrenocortical hormone abnormalities, and neurogenic inflammation. Pretty tough deal, right, for something that is the most common form of chronic prostatitis in men. So don't get that. This is what I can tell you. Now, if you do a digital rectal exam on someone with acute prostatitis, you will see that you need to know how does it feel. So it will feel like what you call dough-like, which in Arabic means what? Ajeen, exactly. It will feel like ajeen when you do it. And it is painful and swollen on the digital rectal exam. Just make sure that you don't play with it too much, because it will result in exquisite pain, and also you may be, believe it or not, be releasing pathogen into the bloodstream, resulting in sepsis. You do that everywhere. Where else in the body you need to be very careful about, handling a tumor or handling an entity. Not in the testes.
Pap smear. Pap smear. Pap smear.
Pap smear. No. How about adrenal tumors? Which adrenal tumor you have to handle with extreme care? Because if you don't and you start to, let's say, fiddle with it, pheochromocytoma, that may actually kill the patient. Where else in the neck? You have to be very careful about thyroid, exactly, because you may be causing actually inflammation in the thyroid. If it's inflamed, that may actually result in it extending outwardly into the blood. All right, so this is actually when it comes to prostatitis. Now, a biopsy for prostatitis is not needed. It's a clinical exam, clinical and lab exam that you need to do. Of course, If it is, the chronic abacterial prostatitis, which is the most common, unfortunately, you need to go through the hoops of documenting inflammation in the absence of infection and in the presence of those kind of presentations. Psychological presentations, as you can see here, immune dysfunction, neurological, and endocrine. Go ahead.
How sensitive is the digital rectal exam to not need a biopsy?
No, you don't do the DRA because it's the digital rectal exam is only one part of the whole, actually, of the whole presentation. You're absolutely right. You cannot depend on it. Even, let's say that you actually, put in your finger and you found out that it is rubbery and it is rubbery. What's the other name for it? Let's see. No, the. I have a problem. I told you sometimes the neurons, cut at certain points in my brain, and that's not fun. What is that? I'll remember it in a second. Let's say that it is rubbery, right? Large and rubbery. Does that rule out cancer for you? Absolutely not. Still, this is where pathologists will come in and will tell you the gold standard is the tissue diagnosis, But you don't need to go all the way. The reason why, actually, it's a couple of things. One of them, prostatic biopsy, you try to avoid it like the plague. Actually, one reason why the PSA, which used to be used to screen for, prostate cancer, has been, curtailed significantly. Because the minute that you get actually an abnormal result, what is the next step?
Biopsy.
The biopsy. But they found out that there is actually poor correlation between the PSA values and the biopsy findings, meaning the positive predictive value of the test is not really so great. And you're putting the patient, how do you do the prostate biopsy? Do you guys know? It is general anesthesia. The patient will be, you have to book the OR for the patient, Your patient is going to be, it's very painful. Here's another thing, actually. And then if you're doing it for an itis, for an inflammation, that's a big deal, So you try to avoid it like the plague. There is only one condition with prostatitis where you have to consider, or you consider doing a biopsy, and that is actually with the granulomatous inflammation. And how does that happen? If your patient has a history of BCG that has been instilled into the urinary bladder. What is BCG? Do you guys know? Vaccine, right, exactly. Was BCG, in the news recently? Yes, it was. They found out actually that when they looked at the distribution of COVID-19 cases in the world, those countries that were actually implementing the BCG vaccination have less prevalence and incidence rates of COVID-19 than those countries that did not use BCG, meaning that the BCG have offered actually immunity against COVID-19. Now, but in this instance, this BCG, has been found, it was a side effect, if you will, has been found that actually when it is instilled in the bladder in someone who have urothelial cancer, it will go and destroy that urothelial cancer. How about that? It will destroy the urothelial cancers, especially the papillomatous, the papillary form of urothelial cancer in the bladder. When you instill, the BCG in that, bladder, and it will destroy it using actually a granulomatous inflammation. Now, the side effect of that use is that this granulomatous inflammation will not be limited to the urinary bladder wall, but it may also happen in where? In the prostate itself. So if your suspicion is that your patient, from the clinical history that your patient is having, has actually granulomatous inflammation, you go ahead and biopsy. This is the only time when you do actually a biopsy for prostatitis. All right, here's an example of what you find in acute bacterial prostatitis. I guess you cannot miss it. The pus is everywhere, right? What do you expect to see in chronic prostatitis?
Nothing to say.
Well, that's in a way actually to put it nicely. You can say actually that it will be more fibrotic, right? More fibrotic, pretty large, right? But less. You may see what you call acute superimposed on chronic. That may happen as well. This did not kill the patient. This was found at autopsy. The patient did have this complaint, did have this problem, but it did not kill the patient. It was found on autopsy, and as you can see, it is filled with with pus everywhere right here. Every time you see green, that's actually pus. All right, now nodular prostatic hyperplasia. For a long time, we call it actually benign prostatic hyperplasia, but because this is redundant, every time you use the word benign and you put it with hyperplasia, you're repeating the word because classic hyperplasia is benign by definition. So they chose a new word for it, which is nodular prostatic hyperplasia, NPH. Okay, NPH is an entity that all of us, all of you guys, will have at certain point in time. The older you grow, the older you get, the more likely that you're gonna get it. Okay, so it is what do you call it? It is a destiny, definitely. It's gonna be fulfilled, and present a significant number of men by age 40. This is when it starts. When it really hits, that's actually when you start to look at the 80s and the 90s. You will see almost 90% of them who are hit with those kind of presentations of nodular prostatic hyperplasia. What happened in it is that both the stroma and the glandular epithelium has grown, outgrown actually, its original size, and as a result of that, the prostate itself is going to present, with a lot of growth in the transitional area of the prostate, in the area surrounding actually the urethral cruise, if you will. And as a result of that, the prostatic urethra will be compressed by this growth. This is actually where the basis of all the presentation that you see in nodular prostatic hyperplasia. So you will see a lot of actually nodular growth, and those nodules are going to be centered in the middle of the prostate, in the transitional zone of the prostate. It is resulting from the androgen. This is the culprit of this. So from the DHT, it is from within, In Arabic we say, right? You guys know this saying. That's exactly where it's coming from. It is coming from the effect of the androgen on the prostate. And we have actually evidence to that, very strong evidence. Keep that in mind, very important. Is that MPH does not happen in castrated men before the age of puberty, and also it does not happen in genetic disease that block androgen activity. So both actually evidence are very important to keep in mind that in those men, MPH does not happen. Why does it happen? Because there is no androgen in those men. Okay? Now, most of the action is still due to the DHT, and you know where the DHT is coming from, as we have talked a minute ago. Okay. Now, clinical manifestation appear in just 10%. I mean, that's incredible, because if you really read the clinical presentation of older men, you have to say probably this is at least maybe 60, 70%. And here, Robbins say that it is present in only 10% of men with pathological evidence of MPH. Now, because of the location of the pathology, it is actually related to the urinary stream. So the patient, when he tries actually to empty, to void his urinary bladder, what's going to happen is that he will be facing actually an obstruction, right? So there will be delay in starting the urinary stream. And then when it started, this nodular growth, as you can see here, is going to be actually collapsing the urethra. So there will be interruption of the stream. And there will be inadequate or incomplete emptying of the urinary bladder. So there will be stasis, and there will be dribbling as a result of that. And eventually, as a result of the stasis, this may result in infection and urinary stone formation, and also possible chronic inflammation that may result in development of cancer, or very remotely in development of cancer. All right, so this is what we have talked about. Look at the slit-like opening right here. This is the prostatic urethra. You see all these nodules. This is actually the MPH surrounding the urethra. So remember, in castrated men before the age of kids, I should say, before the age of puberty, this will never happen. Why? Because there is no androgen. In males, that have syndromes of androgen, insensitivity, also this is not going to happen because of the fact that there is no androgen to work on the glandular epithelium. Here is actually an example of what will happen when you have such a thing. So the end result, as you can see, this is the bladder actually projecting itself, into the urinary. This is the prostate, in projecting itself into the urinary bladder, and you can see the urinary bladder wall, right? What are these
Hypertrophied.
Trabeculations, exactly, trabeculation. And this is a stone that has formed as a result of the stasis that happen in the urinary bladder because of the difficulty in emptying the urinary bladder completely. Here is the trabeculation that you can see it, a better picture here. If you recall, we talked about the acquired diverticulum that may go through it, that may result from this as well. So what to do about it? Remember that this is how it is. I guess, surgery is not really very hard to get, right? So they go inside. Any one of you cook? I did ask this question before. There was one guy who cooked here. He was sitting at the end. Cook. Do you cook?
Yeah.
Do you know how they do eggplant?
Yeah.
Yeah.
So they go inside and they start to scrape, right? That's exactly what they do here. They start to scrape this region. The more they scrape, the more actually opening is going to happen, right? This is a very bloody operation, by the way. So there will be a lot of blood that will be lost, and the result of this operation will be what you find here, the prostate chips. And the name of the operation is transurethral resection of the prostate, because it is through the urethra that you go in and you start actually taking out. It's a very painful operation, very serious operation, if you will. Of course, it has to be done under general anesthesia, and it's also a very serious, case for the pathologist, because the pathologist has to go through all of these pieces, documenting first the presence of nodular prostatic hyperplasia, and two, the absence of cancer, because there can be cancer lurking somewhere in one of those, chips. When you take a section of those actually chips right here, if they are all benign, that's what you're going to be seeing, those very large, glandular structures. When you go on higher power, you will see that, you can still see that the stroma is open, meaning there is no invasion. There is no, what you worry about in the prostate pathology is the smaller glands. The smaller gland with jagged edges, meaning infiltrating edges, that looks like a pointy edges. That, and then you start to see them between the different, lobules. Here it is still actually open, so there is no such thing as invasion. You go and look on the, on higher power, and you're going to be finding actually that there is still the basal cell layer pretty intact. You look at the cytology of the prostatic epithelium, and it looked very benign, what we call unimpressive or bland. It's still benign. There is still maturation toward the surface. There is no dysplasia. There is no NC ratio, increased NC ratio. And everything looks hunky-dory. Now you look at this. What are these guys? You guys know? These are concreted secretions of the prostate known as corpora amylaceae. Does not have any clinical significance, but it is seen usually in examination of the prostate. Right. So this is NPH. Now we're going to be talking about prostatic adenocarcinoma. Now you will see a lot of similarities between prostatic adenocarcinoma and NPH. Both of them happen in the same age bracket. Both of them, increase in incidence as the patient lives longer. So you will see that someone who is at 80 years of age, have a significant actually chance of, having prostatic adenocarcinoma. Both of them, NPH and prostatic adenocarcinoma, are dependent on androgen. So in terms of pathogenesis, they have the same pathogenesis, the same exact findings. We have seen that when someone is castrated, the patient is not going to be developing prostatic adenocarcinoma. Someone with syndromes of androgen insensitivity will not go on to develop prostatic adenocarcinoma. Why? Because the androgen, the testosterone, is not really having its effect. Now there is a couple of differences as well. Where does actually prostatic adenocarcinoma come from? It comes from the peripheral posterior. So as a result of that, you see that the patient with prostatic adenocarcinoma will not present with urinary symptoms. Unless it is a very advanced case, that's when the tumor has gone out and has moved to other parts and into the transitional zone and surrounded the transitional zone. So if a prostatic adenocarcinoma patient presents with urinary symptoms, you know right off the bat that this is an advanced case actually. This is one indication that it moved, actually started in the back and moved elsewhere, and as a result of that, the patient is presenting with this with this urinary symptoms. All right, so this is here's actually a great saying, from one of the articles that we use for this. They say many more men die with the disease than of the disease. Okay, most of the at least this is what those new references are talking about, is that the majority of patients, and I can probably stick my neck a little bit on this, a majority of patients of prostatic adenocarcinoma are actually harboring what we call insignificant clinical tumors, meaning they are not really the reason for the demise of the patient. The patient died for other reasons, most likely cardiovascular reasons. But during autopsy, because in the West they do autopsy almost on every, especially if it's a hospital autopsy, especially if it's an educational institution, they do autopsies on every patient. The autopsy is a great way to learn actually about what happened and what did not happen. It's a great way to know about pathophysiology, and it's the best quality assurance and quality control method in any hospital. It is really, you will see everything that was done to the patient in a single exam during autopsy. All right, so they will do the autopsy, and an incidental finding will be the presence of those of this, tumor, prostatic tumor, usually small foci in the patient. High in the U.S., especially in African American, I told you the white race is usually a protective factor, and lower incidence among Asians. Okay, now you can see actually that is going to be also part of the pathogenesis of prostatic adenocarcinoma. One of them is the race. We can see that there are actually certain genetic focus or genetic loci actually for both African Americans and whites in the U.S. that are correlated with the development of prostatic adenocarcinoma. All right, so what are the pathogenesis? Androgens are right at the top, and we have talked about this a second ago. Heredity, environmental factors, especially that has been confirmed with migration studies, especially for the Asian population that moved into the U.S. And the incidence of prostatic adenocarcinoma in Asian countries is pretty low. Once they go into the U.S. and they actually are hit with the fast food culture, you will see that actually the incidence will increase. So it will be higher than the mother country, but it will not be as high as the U.S. itself, the U.S. population itself. There are actually significant number of acquired somatic mutations that we'll talk about, also some epigenetics related to the pathogenesis of prostatic adenocarcinoma. So androgen is the central role. This is actually the ground zero for the development of prostatic adenocarcinoma. I did mention to you the example of castrated men and also men with syndromes of androgen insensitivity. Now, one thing actually I want you to know is that it is not only there to kickstart the process, but also to maintain the tumor. So if you take, this is really where actually the treatment of prostatic adenocarcinoma came from. So if you go and simply cut or reduce the androgen in a patient with prostatic adenocarcinoma, what do you think will happen to the tumor? It will shrink. It will shrink. It may disappear. It may be gone completely. What is the best way to actually, what is the best anti-androgen in the world?
Estrogen blocker?
No.
Something with the letter F.
Oh, sorry, that is
Letter
F.
F? What is F?
I forgot the name of the drug.
No, come on. Philistrine?
Philistrine,
No.
right?
That's not, I'm a pathologist. I
Estrogen?
have no idea what philistrine is. Go ahead.
What's the question?
What is the best anti-androgen in the world?
Estrogen.
Estrogen, absolutely. Always, the female hormone. I call it the magic bullet, really. If you look at the female hormone, it is the magic bullet. At one point in time, they will start actually recommending that all men around the world start to get, weekly shots of the estrogen hormone. I mean, you're kidding? Look, what could protect your bone? Estrogen. What could protect the heart? Estrogen. What could protect the skin? Estrogen. What could protect against prostatic cancer, which is now, believe it or not, the most common tumor causing death in men, and also in some countries the most common overall tumor. It surpassed even lung cancer. Go ahead.
Doesn't it also cause cancer?
Well, in men it will not because you have androgen, so it will go against it. In females, yes, too much of it will cause what you call estrogen-dependent tumor. You're absolutely right. All right, so again, I'm just, of course, this is done to make you think about it, right? But in reality, it is actually there's evidence that this is the case. Now, scientists came and say, okay, but there is a group of tumors, guys. There are a group of prostatic adenocarcinomas that are not responding to the estrogen treatment, to the anti-androgen treatment. And that was their basis actually to say that there is a second mechanism, a second major mechanism that could be actually the reason why prostatic adenocarcinoma developed in the first place. It turned out actually that those group of tumors have a mutation in their androgen receptors. So what you call activating mutation, meaning their receptors are firing continuously into the nucleus. Similar to what you have seen or learned in POD. What was the gene that was actually when it becomes activated and keeps firing into the nucleus? The c-MYC gene in the neoplasia part of the POD, if you guys remember. It keeps sending in actually when it becomes activated as a result of another defect in a nearby gene. That's going to result in it actually firing. This is exactly what happened here. The androgen receptors will be firing into the nucleus, putting the prostatic epithelium into a hyperdrive of division, and the end result is going to be tumor formation. So even in those subset of tumor, it was found that androgen is actually the cause of this. That it was not a second mechanism. It was also related to androgen in a different way. All right, heredity. Now we know that there is increased incidence of prostate carcinoma in first-degree relatives of patients with the disease. And genome-wide association studies. What is the genome-wide association study? Do you guys know? So instead of doing a PCR, which is when you look at one gene at a time, or southern blot, or any kind of other now we have tools where you are going to be looking at the full genome at once. The best tool of this is what nowadays? Sequencing. NGS, next generation sequencing. You can sequence the human genome commercially, if you want, right here in Riyadh in less than 1 day. You're going to get a full readout. The thing is, who dares actually to do this? I'm scared to be, to discover, what I will find out, if I do this, NGS study. So I will not do it, even if you give me money to do it. Right, but when you do this kind of, studies, you will be looking at the whole genome. So you will be able to see what's up, what's down, and what stays actually neutral in, let's say, cases of prostatic adenocarcinoma. So they found out that the c-MYC oncogene on chromosome, on the long arm of chromosome 8 appears to account for some of the cases, just talked about the c-MYC right now, for some of the increased incidence in African American patients, and in white Americans, white people in the US, it is actually chromosome 1. The long arm of chromosome 1 that has been linked to development of the disease in this population. Environment, I did mention to you the migration studies. Those Asian people who moved to the US increased their incidence. Why did they increase their incidence? Because of these, 4-letter word, the diet. Okay? I think it's part of the social experiment, really. The more fast life you live, the more likely that you're going to be working and your spouse will be working as well. The less likely that you or your spouse will be cooking. The end result of that is going to be that you will be depending on diet from the outside, and you have a good idea, what this diet from the outside is going to be loaded with. It's going to be loaded with everything that you don't need. And fat actually is a very important risk factor. Fatty diet probably is the most important environmental risk factor when it comes to prostate adenocarcinoma. Here's another great, actually, I would say, postulated cause or hypothesized cause of the disease, and that is the TMPRSS2E2S. So what is that actually? Now, it's a fusion gene. But this fusion gene is not associated, it is not listed with a translocation. How did this happen? Usually when you have a fusion gene, there should be translocation, right? You know, a gene broke and then came here, and then another one came here, and you know, there was a fusion. Why, how did this happen without the fusion, without translocation? Deletion. So it is on the same chromosome, right? Both of them are carried on the same chromosome. There was a deletion in that chromosome that resulted in juxtaposition of the two fragments next to each other, resulting in the creation of this fusion gene. What does that fusion gene do? This fusion gene is going to be actually resulting in uninhibited proliferation of prostatic epithelial cancer. We have seen that in POD with the BCR-ABL, if you guys recall, and in other also fusion genes that have this kind of ability. You know, in terms of actually it is prevalence, they listed up to 70. You know, what you call fully trusted autopsy series shown that actually it is about 50%. So the prevalence around 50% in prostatic cancer. Here's another actually way for, or you know, risk factor for the development of prostatic adenocarcinoma. You know, there is what you call, you know, epigenetic mechanisms. So it is not simply, you know, the genes itself that are going to be, you know, coding for the genetic material. There are other factors from outside the genome that are going to work actually on either expression or actually knockdown of certain, you know, genetic material or genetic messages. You know, the most common epigenetic mechanism is hypermethylation. Hypermethylation that could actually do a couple of things. What could hypermethylation do to a gene?
Prevent transcription.
Only?
Or overexpression.
So it could do what?
Make it divide and
Activate.
Does it actually knock it down or does it activate it?
Knock it down.
It can do both actually. It can knock down a gene and it can activate a gene. Okay? So depending on which gene, depending on the circumstance per se, it will be having a different kind of effect. It may actually, the same epigenetic mechanism, which is hypermethylation, could knock one, you know, gene down and could upregulate a second gene that is nearby. Okay? And it was found out that actually one gene, when it becomes hypermethylated, it may actually relate to the development of prostatic adenocarcinoma. This gene is the GTSP1 gene. So what is that gene? This is a gene that is related to the effect of antioxidants. If you guys recall, again from the POD, when I mentioned to you, I'm not sure that you do, but if you do that, that will make me happy, is that actually free radicals, if you really think about it, are going to be the most common cause of cancer. If you think about it, it is always going to be related to, you know, the presence of, you know, free radicals and how they are actually going to result in their effect on the genome. What does free radical do on the genome of the cell? As you know, free radicals have affinity to three things. One of them is cellular membrane, okay? 2, mitochondria, and 3, the genome of the cell. But my question to you is, what do free radicals, you know, cause in the genome of the cell?
They take an electron from the base.
They do what?
They break the DNA.
Double strand break, absolutely. This is the most common, excellent. So this is one of the most common kind of actually effect of the free radicals on the genome that may actually result in, you know, in neoplastic transformation. But there is a long list actually of not just double-stranded breaks. There is a long list of actually of changes, you know, that are less likely to happen. But when it happens, including translocation, including deletions, you know, point mutations, all of them may actually result in neoplastic transformation. And you know, how is that related to the GTSP1? When this GTSP1 becomes actually hypermethylated, then this antioxidant protein and detoxification enzymes are no longer be functioning. Okay? And that's so the cell will be left to its own design to deal with the free radicals. And as a result of that, free radical injury is certain to happen in those cells, and the end result will be neoplastic transformation. Of course, none of them is 100% cause of prostatic adenocarcinoma. It's what you call a multifactorial disease. So you will have the androgen effect. You're going to be having one of those genes that is going to be overexpressed. you can see that it is found in 90% of primary prostate cancer. That's an incredible, actually, prevalence rate. It could be the diet as well is happening in those patients, and the end result is going to be the neoplastic transformation. So it's a matter, that's what they would say. Personally, I don't believe, I don't believe it. It's a matter of chance, but at the same time, actually, it's a matter of so many right things happening, if you want to call them that, that eventually the end result will be the development of the cancer. You have to have all the ducks in a row for the tumor to develop in man. All right, so those are what I mentioned to you: dying with the disease, then dying of the disease. So most of them are small, insignificant tumors, and discovered on needle biopsies for work of an elevated PSA. Right. So when you're going to be doing the DRA, very likely you're not going to be able to palpate those small tumors. And when you do palpate it, it would have been significant. It would have grown significantly. Now the question that should come to mind is what to do in order to catch the tumor at its earliest, at the earliest stage. Before that, how does the tumor spread? The spread, the local spread happens through the perineural space, a very unique feature for prostatic adenocarcinoma. The mets happen through lymphatics and hematogenous. So what, here's coming back to the question that I asked you. What is the tool that you want to use in order to catch the tumor at its earliest? We thought that PSA is going to be the answer to that. The prostate-specific antigen, which is actually produced by the prostatic epithelium. All right, and there are what you call cutoff points for normal. We do have cutoff points for normal. We have 4 to 10 nanogram per milliliter. The problem with these cutoff points is that it does not apply to all cases. We have limitation to this test. So when it comes to it actually being used for diagnosis, we cannot really use it for diagnosis. The best use for PSA is for monitoring treatment of prostatic adenocarcinoma. Because if you think about it, if you take out the prostate, what should be the PSA level? It should go down, it should go to 0, right? If you take it out, if you take out the prostate, either hormonally or radiologically, by irradiation. How do you do irradiation to the perineum? Is that a good thing to do? You have this very soft, very fuzzy borders, right, in the perineum that you're doing, and then you're hitting it, with this beam of radiation. What is that going to result in? A lot of burns. That's going to result in a lot of fibrosis, and a lot of damage, right, for that region. So how do you go about actually irradiating the prostatic adenocarcinoma without causing this external injury? When I was doing my residency in the state, this is actually 20 years ago. I'm not sure if it actually went out of the US. The center where I was using what you call radioactive seeds. So I used to receive these actually prostate, and in it, when I was sectioning it, it does have these black seeds, in it. And then, I went, because I tried to read about it. It was not in any book that I read at that time. It was, an experiment from the center itself. And I was told by the surgeon who was actually, doing the surgery, that the radiation oncologist placed these radioactive seeds into the prostate, and those radioactive seeds are going to radiate the foci of the tumor directly, without having to actually damage,
Like gold?
the organs and the site as the radiation beam goes in. Okay. Have you guys heard about it before?
No.
I think gold.
Actually, one of my, have you?
No, it was gold. I think they use gold.
Gold? No, not gold. No, just the radioactive seeds. I mean, obviously, radioactive material, but very miniature, very small, And one of the graduates of our school, his father had actually prostatic adenocarcinoma. I did, tell him to go and ask about it. He told me he could not find actually that, the surgeon that he talked to told him that this, happened, but it is not here, and they went actually through chemotherapy for his father. So just a point that I wanted to make when it comes to that. All right, so PSA value. So here's the flow of things. We have tests what we call screening test. All right, screening test for different types of cancers. Now the screening test should be what we call a reliable test, meaning it should have good correlation with what is present in the tissue. If you don't have this correlation, it will result in a lot of unnecessary headache for you, for the patient, and also for the medical, insurance system. And it was found actually that when it comes to PSA itself, when it is used as a screening test, as a single, point in time kind of test, it does not have that much value. So when it comes to actually follow-up after treatment, it's a great test. So you do treatment for this prostate, you take out the prostate in any way you can, surgically, hormonally, or actually radiation-wise, and then you actually measure the PSA value in time. After knowing the half-life of the PSA, you expect actually that the PSA value will be coming down to 0. If that did not happen right after treatment, what do you expect? What do you expect that happen? Metastasis or residual tumor, that you did not take everything out. If it went down to 0 and then after a while it came back up again, what do you expect that happen? There is a recurrence or metastasis that actually are producing the PSA. So it's a great test for follow-up, but when it comes to screening, because of the poor correlation with the tissue findings on prostate biopsy, it's really discouraged to be used. Now there are actually what you call refinements for the PSA test. Before that, the cutoff point, again, another weak point is when you have the cutoff point of the test that you cannot trust 100%. Meaning less than 4, we have someone, so 4 to 10 is normal, less than 4 is great, right? What if someone actually present, if you have done the testing over, let's say, a period of a year, beginning at the end of the year, and you have found out that actually the starting level of the PSA is 3.5 for this patient. At the end of the year, you found out that the end point of the PSA testing is actually 5.0 nanogram per milliliter. 5 is between 4 and 10, right? So you should say that this is normal, correct? No. In reality, because the increase was so significant over a 1-year period, it fits the definition of actually a prostatic adenocarcinoma. So if you do biopsy on this patient, you will find actually that this patient does have prostatic adenocarcinoma on the needle biopsy. The reason for this is that the velocity with which the PSA has increased fits the criteria of a very worrisome PSA value, even though it is within the normal boundary of 4 to 10. Someone with actually who is at 50 years of age, you actually do the PSA value at this patient at 50 years of age, and then you do it at 80 years of age. Do you expect the two values to be the same?
No.
The answer to that is no. Why? Because the glandular epithelium has increased in size. This glandular epithelium is what produces the PSA. So the value that you're going to be finding at 80 is going to be much higher than what the patient was presenting with when he was 50. So they started actually to think that the best way to address a PSA is through the introduction of what you call, again, I take that back, another limitation. The PSA is not actually a test, that is cancer specific or diagnosis specific. So it is increased. I have you for 2 hours, right?
Yeah.
So it is increased in all different diseases that will affect the prostate, including prostatitis, including actually infections, including NPH, nodular prostatic hyperplasia, infarcts, instrumentation, and ejaculation. So there is a long list of variables, what we call, that could actually affect the level of the PSA. Now, one actually application for the PSA that is great is that you can use the fact that it is what we call a tissue-specific test. because a lot of times, because of the direct proximity, the close proximity of the prostate and the urinary bladder, one tumor could start in one organ and end up in the second organ. So the question will be, am I actually looking at a urinary bladder tumor, a urothelial tumor, or is it a prostatic tumor? And if you do the PSA and it was high, you know right off the bat that this is actually a prostatic adenocarcinoma. So it is what you call tissue specific, but it is not cancer specific. Here's another drawback. 30% of prostatic cancer with organ confined, meaning that the tumor did not go anywhere, have a value of PSA of 4 or less. That's what you call another actually stab to the value of the PSA and to the use of the PSA as a screening and a diagnostic test. All right. So another drawback. Are you guys with me?
Yes.
You're done? Okay. Now, prostatic intraepithelial neoplasia. You would hope, or you would have hoped, that PIN, which is the equivalent of carcinoma in situ, will also be presenting with actually high PSA, right? Because that is going to actually make you catch the disease at the most earliest. Unfortunately, high-grade PIN is not, or does not cause an increase in the PSA. So what you call it, like when you go into a boxing match that is not really quietly matched, you are, with a big, boxer that is, hammering down on you, one after the other. That's exactly what they have done to the PSA. So now scientists actually and clinicians start to suggest what you call test refinements. One of the best test refinements that they suggested is what is known as a sliding scale refinement. Sliding scales that is going to tell you a patient in this age should have actually this boundary for the PSA value. All right. So by doing this, you actually are taking into account the size of the prostate with regard to age. A very important actually introduction to the use of the PSA. Another one is to look actually at the speed with which the PSA has increased over a period of time, as I mentioned to you in the beginning. So if this increased by 0.9 nanogram per milliliter over a year period, you don't care about where the value is, because that PSA is already suspicious and you need to intervene and do a biopsy. Okay? And 3, it has been found actually that what matters the most is not really the full PSA value, because the PSA is mostly bound to protein. Okay? It is actually the free PSA value that is mostly related to the presence of prostatic cancer or needle biopsies. So you have to calculate the free PSA and then decide if this actually PSA value is worrisome or not. Okay? 3 refinements. I want you to remember them for the exam. You have a question? You have a question?
My question was about the free and the bound form of PSA.
It is. Okay, very good. Thank you. Any question, guys? All right. All right, so PSA is valuable in monitoring response to therapy. We already have talked about this. This is the best use of the PSA, if you think about it. And serial measurement. This is why actually another drawback that I can tell you is that they said, why do we have, what's the value of testing, a patient at one point in time? We did not know what the patient, PSA value was 10 years ago, at 40 years of age. And the patient is coming now with 50, at 50, and doing this test. It will not really give us, a lot of what you call input about, the increase or the plateau of that PSA value. So they suggested serial testing, but it was not part of the refinement of the test. All right, do you guys want to take a break? Is it time? Is it time?
2
All right, 2 o'clock. Okay, so you can take 5 minutes, 10 minutes. All right.
Yeah, that's all.